This lecture is to talk about acute lung injury, ALI, or acute respiratory distress syndrome, ARDS. Well, the name suggests that it's acute. So it's a sudden onset. So some type of a trigger, all right? It's non-cardiogenic that causes alveolar capillary damage. Okay, so both alveoli and capillaries that are needed in a gas exchange are affected suddenly, not due to a cardiogenic defect or abnormality. So since it's acute, you're dealing with this condition in hours to days after having a normal or functional lung. Okay, so rapid onset is the key thing. Progression over several hours of dyspnea, hypoxia, diffuse bilateral pulmonary infiltration, meaning capillary content entering the lung tissue, causing inflammation within the parenchyma, and alveocapillary injury, including endothelium, surfactant inactivation, then causing stiffening and non-compliance of the lungs, edema, atelectasis, causing respiratory failure. All right, so you're familiar with edema, you're familiar with atelectasis, you're familiar with inflammation within the lung already by discussing many other respiratory disorders. So basically here, all you want to plug in is it's a sudden event, okay, affecting the lung function, and it's independent of the heart condition, okay, and main cause is injury within the lung tissue, inflammation. So injury, inflammation, causing surfactant inactivation, then the stiffening of the lung tissue, edema, and atelectasis. All right, so with this, we will talk about additional details. What are those risk factors in the development of ARDS? Shock, all right, many types of shock, septic, cardiogenic, or hypovolemic shock, trauma, okay, chest area specifically, infection within the lung, and disease states that would trigger inflammation, exposure to narcotics and barbiturates. This is where it's important for you to pay attention, okay? Exposure to these toxic agents, some of the anesthetic agents, or toxic or not so safe. Now, they could trigger the ARDS like symptoms: aspiration, pancreatitis, and uremia. Urea in large amounts in the blood is uremia. Pancreatitis is inflammation of the pancreas that now targets the lung tissue. Aspiration is where the content from the digestive tract will make its way into the respiratory tract, and the acid content of the gastric content, the acid in here is going to cause injury to the lung tissue, therefore inflammation. Here is a way to study how it can be complex with more than one risk factor. So one risk factor incidence of ARDS is about 25%. 2 risk factors, 42%. 3 would be 85%. Okay, so mortality rate is 50 to 70% and exceeds 90% in the presence of septic shock. All right, so pretty serious matter looking at these numbers. Now, let's talk about the different types of situations in a timeline fashion. Initially, it's exudative or inflammatory. So this is within 72 hours. All right, exudative is, as we talked about, either the fluid or the cell debris in the tissue. Okay, inflammatory is where there is inflammation due to infection, due to other risk factors we talked about. Then you have proliferative. This is basically the expansion of the inflammation into the rest of the lung tissue. Then the last stage is fibrotic tissue that went through the inflammatory changes will now be converted into the fibrotic tissue. All right, so let's look at each and every part here. The first phase is alveolo-capillary membrane damage. That is alveolar and capillary. Basically, it's the respiratory membrane damage. Now, capillary membrane permeability would increase, allowing fluid and cells and plasma proteins to escape into the lung tissue. That leads to pulmonary edema and inactivation of surfactant. Now, proliferative phase is where resolution of the pulmonary edema and proliferation of type 2 pneumocytes, fibroblasts, and myofibroblasts. Okay? So you may not have edema at this point, but instead it is the type 2 cells, basically surfactant is now re-synthesized. But the other thing you have to notice is fibroblasts being active, secreting these collagen fibers. And myofibroblasts, again, smooth muscle proliferation, and fibroblasts are adding more collagen fibers, elastic fibers to the area. Hyaline membranes is going to appear. This is hyaline fibrous sheet. Hypoxemia is decreased oxygen in the blood. Now, later on, remodeling of the area that was affected within the lung and fibrosis. You already know the activation of fibroblasts and myofibroblasts here. That is what is going to cause fibrosis. Alveolar destruction, severe right to left shunting, acute respiratory failure. Okay, so this is where the alveoli are destroyed. That means blood supply would be shifted to the healthy parts of the lung. All right, so that is the duration and the changes that it would take for the destruction of the tissue within the lungs. All right, here is acute lung injuries summary in detail. The causes are mentioned: pneumonia, aspiration, smoke inhalation, sepsis, as a few examples. We have looked at others. And now, release of inflammatory cytokines. Okay, they would attract white blood cells, such as macrophages, neutrophils, as well as platelets. Now, the release of reactive oxygen species, harmful agents like proteolytic enzymes, more cytokines, all right, platelet activating factor, PAF, and complement activation. All right, so all these agents being released would affect many functions. I'm going to take you through this right route here. A platelet activating factor would act platelet. That would then lead to the building of a blood clot. Okay, vasoconstriction with decreased flow to some lung areas. Okay, so now you're talking about microthrombi affecting blood flow, causing vasoconstriction, and that leads to pulmonary hypertension. Well, if the vessels are occluded, the remaining vessels with more blood would have higher pressure, pulmonary hypertension. That leads to VQ mismatch. All right, so let's talk about other changes here. VQ mismatch, we would need to take it to acute respiratory failure. That's one thing. Now let's look at inflammatory response causing damage to endothelial cells, damage to alveolar cells. Both are affected. Disrupted alveolo-capillary membrane. So we really started off here in the previous slides, but you know the cause of that. Exudation of fluid, protein, red blood cells into the interstitium because of the damage to the capillary, decreased surfactant production, therefore, more surface tension than normal, that leads to collapsing of the lungs and decreased lung compliance. Now, exudation of fluid, protein, red blood cells into the interstitium would interfere with Starling forces. More fluid remains in the tissue than back into the pulmonary capillary. So now edema is another concern. Pulmonary edema and hemorrhage with damage to the capillaries. Severe impairment of alveolar ventilation, exudative phase. All right, so proliferation of type 2 pneumocytes, fibroblasts, myofibroblasts, formation of hyaline membrane, all of that is basically in the second stage we talked about. This is where you're trying to recover from the inflammatory stage, but this is leading to a more unique or a different setup where you have fibrous tissue being constructed, all right, by the activation of many of these cells. A progressive fibrosis next, and tissue remodeling, that is destruction of alveoli and bronchioles. You just have fibrous tissue there, all right? So if you have healthy tissue that's replaced by fibrous tissue, you do not have much healthy tissue to live on, you see? So it depends on the area that's lost, and if it's a smaller area, the rest of the lung will be able to manage the gas exchange. However, if the area is significantly lost, then that could lead to respiratory failure and death. You are talking about hypoxemia, hypercapnia, acidosis. All are the consequence of respiratory failure. Decreased oxygen in the blood, buildup of CO2 in the blood. Acidosis is because of the buildup of CO2 in the blood. Good. With this, It's just a summary of what we have talked about. Okay, hyaline membrane, this is a cartilaginous, basically connective tissue growth. All right, atelectasis is collapsing, showing hyaline membrane shown many places here. Atelectasis, alveolar consolidation. We'll talk about alveolar consolidation next. So that is the structure that's supposed to be filled with air is now filled with fluid, debris, cells, proteins, and so on. So that's what you call as alveolar consolidation. Okay? All right. So what are some of the clinical manifestations? Main ones are shown here: dyspnea, hypoxemia, poor response to oxygen supplementation. So, you don't have the alveoli to respond to the oxygen supply, isn't it? So hyperventilation, respiratory alkalosis, all of those are the negative feedback effect of what's going on with acute lung distress syndrome. Now, tissue perfusion would be reduced because of the injury that's going on, metabolic acidosis, and organ dysfunction, increased work of breathing, decreased tidal volume, hypoventilation, and that leads to hypercapnia, respiratory acidosis, worsening hypoxemia, decreased cardiac output, hypertension, death. So these sets of events have been discussed before, so we don't have to spend time on the same thing again. But you can tell that when the lung function is compromised, these are the set of events that follow. Okay, so the thing that you may want to remember is poor response to oxygen because of the injury within the lung tissue that affects both the capillary and the alveoli. Let's talk about pneumonia, one of the major causes of inflammation. All right, it's the infection, bacterial or viral infection causing inflammation. Okay, it could be acquired in the community or within a hospital setting. The routes of infection can be through aspiration, inhalation, endotracheal tube, and suctioning. So this is where you're in the hospital and you have this viral bug on things that are used to test or treat, and that would be introducing the infection. Okay, the respiratory defenses have not been able to destroy the microorganisms. So we have innate immunity that you already are familiar with. That has not been helpful, and the entire immune system probably was not able to stop it because it's probably more aggressive or faster than the immune system can get to. All right, now let's talk about one specific type of pneumonia. This is aspiration pneumonia. Okay, aspiration is when normal protective reflexes are not able to protect. You have mucosal antibodies. The type A, IgA is one such a protective measure. Mucus is there, the cilia is there, and tonsils are there. But you have gone beyond the protective measure. Okay, three broad categories of failures are depression of reflex protection. Okay, so body probably is now susceptible to infection. It may be the weak immune system, age, so many other things. Okay, infection being more faster than the immune system can help. Alteration in anatomic structures. Okay, so loss of cilia, loss of mucus in a smoker kind of thing. And iatrogenic disorder is where manipulation in the hospital, we talked about the use of endotracheal tube and such things introducing the pathogen is iatrogenic disorder. So here is a summary of what could go on when there is this infection. Okay, aspiration pneumonia is where you're introducing content from the digestive tract, which travels from the stomach back into the pharynx, ultimately through the airway into the lungs, and there is tissue injury because of the acidic content that leads to collapsing of the lungs. Okay, it's a protective measure. There's so much injury, it causes collapsing of the lungs. Then you have parasympathetic activation that would cause airway closure and decreased lung compliance. And then within hours, you may have turned on inflammation reaction. Okay, so within minutes, you have closed the airway and tried to avoid the exposure to this harmful acidic content. In any case, whatever is introduced into the lung tissue would start an inflammatory reaction within hours. That leads to pulmonary edema and hemorrhage, and then other injury like we have talked about before. Fibrin deposit, necrosis of alveolar cells, all of this has been addressed before, correct? Now, hypoxemia is secondary to atelectasis. Okay, arterial hypoxemia is one of the hallmark signs, and less than 50% lead to pneumonia. So aspiration pneumonia is where the content from the digestive tract in the lung ultimately leading to an infection of the lung, and that's because of injury. Now, opportunistic agents such as virus or bacteria causing infection within the lung. It's called chemical pneumonitis. Chemical is the acid content that's causing inflammation of the lung tissue. Pneumococcal pneumonia. Pneumococcal pneumonia, this is the infection by strep. Okay. So acute lung injury resulting in inflammatory cytokines and cells and edema. So nothing is new here. It's an infection within the lung causing acute lung injury and causing edema. Okay? Edema creates a medium for the multiplication of bacteria, aids in the spread of infection and to other parts of the lung. All right? Involved lobe undergoes consolidation. Okay, whatever lobe is affected, we know about consolidation already, that this is where you replace air with fluid and tissue, like the cells, fibrous cells, and red blood cell platelets. You may also have plasma proteins, debris, etc. within the lobe that's affected. We are organizing this into 4 stages. Consolidation happens first within 24 hours. Red hepatization is where you have the red blood cells in large numbers. The tissue looks like that of a liver. All right, it's usually about 2 to 3 days after consolidation. We have this reddish area within the lung. then the red blood cells being dead and replaced, it's avascular. Okay, gray hepatization is not red, but it is still loaded with cells and tissue and debris. This is 2 to 3 days after red hepatization. Resolution is things being repaired and recovered and basically returning to a normal state. It may not be a normal state because there is fibrosis, there is remodeling, and so on that goes on for weeks. We talked about earlier with ARDS timeline, and you can bring that in here and say this is the consequence that you would expect after the infection is gone. Okay, so pneumococcal pneumonia, it's the strep infection. Aspiration of strep is how we would start the introduction of strep from the GI tract to respiratory tract could be one example. All right, and attached to the alveolar macrophage, exposure of cell wall components of the bacteria. It's basically infection of the lung tissue has happened. Now, inflammatory response, nothing should be new here. It's all discussed. Attraction of neutrophils, release of inflammatory mediators, accumulation of fibrinous exudate, red blood cells, and bacteria, red hepatization, and consolidation of lung parenchyma. We have discussed this now. Leukocyte infiltration. So first is the red blood cell amount being greater. Now you have white blood cells added to this. The tissue now is appearing gray. Gray hepatization and deposition of fibrin on pleural surface. Phagocytosis in alveoli. So basically resolution of infection, macrophages in alveoli ingest and remove the degenerated neutrophils, fibrin, and bacteria. So that is how you bring resolution to this infection. Viral pneumonia is yet another type of pneumonia. This is what we call, as influenza causing pneumonia. All right, viral infection affecting the lung tissue. Seasonal, usually mild and self-limiting, can set the stage for a secondary bacterial infection. So that's the possible effect of viral infection. First you have the viral, but the tissue is all inflamed, and now opportunistic agents reach the lung and cause an infection. So it's like one after another. It provides an ideal environment for bacterial growth by damaging ciliated epithelial cells, which normally prevent pathogens from reaching the lower airways. Most common form is influenza flu. All right, clinical manifestations. Now you probably have an upper respiratory infection before it reaches the lung tissue. Cough, dyspnea, fever, chill, malaise, pleuritic chest pain are typical of pneumonia. All right, so we will stop here and we'll talk about tuberculosis in the next video. Thank you.